Welcome to this training module on evidence-based screening in integrated behavioral healthcare. The author of this module is Julie Barrett Abebe from Westfield State University. We also link to a recorded training on SBIRT provided by Alex Hines of the MassBIRT TTA. This recording is an excerpt of a training that was provided to faculty and staff of Westfield State University Department of Social Work in fall 2018. This training is provided as part of the Interdisciplinary Behavioral Health Collaboration Project at Westfield State University. This project is funded by a Behavioral Health Workforce Education and Training Grant. This training will focus on screenings within integrated healthcare settings. So, let's start with the context of what are integrated healthcare settings? Broadly speaking, integrated care settings are those that provide both medical and behavioral health care services. Behavioral health refers to mental health and substance use treatments. These services can be provided by a range of professionals, including social workers, psychologists, mental health counselors, and addictions counselors. SAMHSA, the Substance Abuse and Mental Health Services Administration, has developed a chart, reproduced on this slide, that designates 6 different levels of integration. Levels 1 and 2 are characterized by communication between medical and behavioral health providers, but not physical co-location. Levels 3 and 4 deepen integration through physical proximity of providers, while levels 5 and 6 focus on practice change for full integration and delivery of holistic care for patients. Practice change might include shared treatment planning, for example. Please refer to other trainings on our IBHC website for more in-depth information about integrated care and interprofessional collaboration. In integrated care settings, behavioral health providers can embed in medical health, the most common setting is primary care, or medical health providers can embed in traditional mental health clinics. Regardless of setting, universal screening has been identified as a strategy for comprehensive and effective care. Other strategies might include warm handoffs, where a medical provider introduces a patient directly to a behavioral health provider in clinic, and team meetings or huddles to better share information on a routine basis. Screening is when every patient is asked a series of questions, typically in a validated questionnaire, about a particular topic or risk factor. Routine screening is used in different medical and behavioral health settings to identify individuals at risk for or dealing with various issues. For example, intimate partner violence, cognitive impairment, and cancer risk are all screens that can be done in different medical settings. However, this training module will focus on behavioral health screenings for mental health and substance use disorders in medical settings. We learned on the previous slide that routine screening can be a strategy for effective and comprehensive care. How? Well, mental health and substance use disorders are very common in American society, but are often underdiagnosed and undertreated. A recent Institute of Medicine report estimated that 20% of Americans are coping with mental health and/or substance use disorders, but current systems of care compartmentalize behavioral health and medical health treatments, leading to inadequate care. Routine or universal screening of all individuals who walk through the door of an integrated care setting can lead to better identification of illnesses or risk for illnesses and referrals to care. Healthy People 2020 particularly recommends depression screening in primary care, given the disability often associated with this illness, as well as the effectiveness of brief screenings for identification of those who are suffering. Research also supports that evidence-based screening leads to increased rates of diagnoses and appropriate treatments, thus leading to improved population health, better use of available resources, reduced healthcare costs, and reduced human suffering. Another reason to do screenings with all patients who walk into an office is to reduce the stigma of mental health and substance use disorders. Historically, societal stigma has been significant and has played a role in individuals' reluctance to seek help. Normalizing mental health and substance use disorders as illnesses that are common in a population and can be treated can help reduce stigma, as can having integrated behavioral health providers in a clinic with medical providers, so that patients don't have to go to separate locations for mental health treatment. It's also important to talk about the use of evidence-based or standardized measures. These are measures that have been developed, tested, and used over time. They have documented reliability or statistical determination that the measure will perform consistently over time, as well as validity, statistical determination that the tool measures the concepts it was designed to measure. Standardized measures are often validated with different populations, taking into consideration such issues as age and culture and language. When a practice uses a standardized measure, it can have more confidence in the effectiveness of screening and can benchmark or compare results to other research studies or practices that have used this measure in the past. Logistically, there are many different strategies that practices use to deliver and respond to routine screenings. Some practices deliver screenings in an electronic format, online through a patient portal, for example, prior to an appointment, or when a patient arrives in clinic by handing them a tablet. Others will use written screening, paper and pencil. Still others will have patients verbally respond to oral questions delivered by a medical assistant, nurse, or other clinician. Considerations for the practice include staffing and staff training workflow, and language literacy of patient population served. Regardless of the method of delivery, there are several best practices to consider when screening. It's important to communicate to patients why the screening is being conducted. For example, we ask everyone a few questions about important health issues, as well as telling patients how the data that is collected will be used. It's also important to obtain permission to ask questions, as well as to provide an opt-out of screening to protect individual autonomy. Finally, it's important to have processes in place to follow up on addressing the needs that are identified in screening. Often, addressing needs entails referrals to appropriate resources. Also, it can include treatment in the setting itself. An advantage of an integrated care setting is that referrals can often happen internally to members of the interprofessional team. Now we will look at examples of evidence-based screening for various behavioral health issues. One option is to use a tool that screens for many behavioral health issues at one time, rather than just focusing on one issue or diagnosis at a time. This kind of screening takes more time for a patient to complete, but on the flip side is more comprehensive. One example is the patient stress questionnaire. This questionnaire is adapted from several other standardized measures, which we will speak about further in future slides. These measures include the PHQ-9, GAD-7, PC-PTSD, and AUDIT. We have included links to measures throughout this presentation. These links are through a helpful website developed and hosted by SAMHSA, as mentioned earlier, the Substance Abuse and Mental Health Services Administration. Here's an example of what the patient stress questionnaire looks like. Another comprehensive measure is the Healthy Living Questionnaire. Please note that the first 8 questions on this questionnaire are copyrighted and require permission for reproduction. This screening includes items about mental health concerns as well as healthy lifestyle choices. From the SAMHSA website, here's an example of what the Healthy Living Questionnaire looks like. As mentioned previously in this presentation, recommendations from organizations such as Healthy People 2020 and the U.S. Preventative Services Task Force specifically include screening for depression in medical settings, specifically primary care sites. Depression is a serious illness and is the leading cause of disability in the U.S. for individuals ages 15 to 44. In line with recommendations, changes to healthcare laws with the Affordable Care Act now cover such annual screenings. The most commonly used screening for depression are the Patient Health Questionnaire, PHQ-9, or, in a briefer version, PHQ-2. This validated scale has modified versions available both in Spanish and for adolescents. Here's an example of the PHQ-9, again, from the SAMHSA website. As you might have noted, there is a question on the PHQ-9 that asks about suicidal ideation. More comprehensive screening for suicide risk might be warranted in specific populations that are known to be at high risk for suicide. For example, veterans. One standardized measure commonly used and translated into over 100 languages is the Columbia Suicide Severity Rating Scale. This scale was developed by Posner et al. In 2008. This is what the Columbia Suicide Severity Rating Scale looks like. Anxiety disorders are the most common mental health issue in the U.S., affecting approximately 40 million adults. However, it's estimated that only 1/3 of those affected receive appropriate treatment. As a category, anxiety disorders include a range of diagnoses, such as generalized anxiety, panic disorder, phobias, and obsessive compulsive disorder. There is reason to believe that medical settings are a particularly good place to screen for anxiety disorders, as individuals with anxiety are 3 to 5 times more likely to go to the doctor's office than the general population. The most common screening tool for anxiety is the GAD-7, developed by Spitzer et al. In 2006. Here's the GAD-7, again from the SAMHSA website. Exposure to trauma is a common experience, with an estimated 60% of men and 50% of women exposed to at least one trauma in their lifetimes. We know from previous research, particularly starting with the ACE study out of Kaiser Permanente, that exposure to childhood trauma impacts health in adulthood, leading to both increased morbidity and mortality. Additionally, a percentage of individuals exposed to trauma develop post-traumatic stress disorder, or PTSD. The life event checklist developed by Blake et al. Assesses exposure to events known to potentially result in PTSD. Here's a copy of the life events checklist. Please note it includes the option for people to check events that happened to them, events that were witnessed by them but happened to somebody else, or events that they learned about that happened to someone that was close to them. A briefer 4-item screen that focuses specifically on PTSD is the PC PTSD tool. It was designed specifically for use in primary care and is used by the VA system. Here is the PC PTSD with the 4 questions. Alcohol and drug use disorders are important to screen for, given the high prevalence, rates of disability, and risk of mortality. According to recent statistics from SAMHSA, over 21 million Americans over the age of 18 suffer from substance use disorders. The audit is a 10-item questionnaire developed by the World Health Organization 37 years ago to identify hazardous alcohol use. Here's what the audit looks like. The CAGE is also a commonly used brief screening tool, and it focuses on both alcohol and drug use. Here's a copy of the CAGE questionnaire. As you can see, it's quite brief, 4 questions. Finally, the DAST is a 10-item questionnaire that focuses on drug use. It's important to screen both adolescent and adult, including older adult populations, for drug and alcohol use disorders. The Alcohol and Drug Abuse Institute Library at the University of Washington also has a helpful database that you can use to find appropriate screening instruments for use with different populations and in different health settings. You can access this resource through the web link on the screen. Screening for alcohol and drug use has become a national health priority. SAMHSA has devoted funding to evaluating promising models of care, including SBIRT, screening, brief intervention, and referral to treatment. This evidence-based model has been used in various health settings to screen for and intervene with individuals with alcohol and drug use disorder. The first step, screening, has already been discussed in this presentation. The next step, brief intervention, includes interventions such as psychoeducation and use of motivational interviewing, which can be done effectively in short, office-based encounters. Please note that psychoeducation might be done for those who are deemed to be at risk based on screening, in addition to those who screen in as having a particular disorder or issue. The intensity of the interventions used shift depending on the level of acuity of the problem that is identified by screening. Finally, the last step in SBIRT is referral to the appropriate level of treatment. This is accomplished, again, based on acuity, also based on available resources, as well as client preferences. Please refer to the SAMHSA SBIRT website, again listed on this screen, as a helpful resource to gain additional information about use of SBIRT. Now we have the opportunity to conclude our training module by watching the accompanying video to learn more about SBIRT. This video is a recorded training that Alex Hines of the MassBIRT TTA provided at Westfield State University in September 2018. Thank you.